Welcome, everyone. Thank you for joining us this evening. My name is Sabrina. I am the program director at the Eating Disorder Foundation, and this is the workshop, Endgame for Recovery, Medication Management, and the Strategic Return to Sport. I'm going to quickly walk us through some logistics for this evening, and then I will introduce Nicole from EDCare to introduce our speaker. So a little about the Eating Disorder Foundation. We are a nonprofit founded in 2003. Our mission is to be an effective resource in the prevention and elimination of eating disorders. We provide free and accessible care. We provide support and advocacy. Though we're a Denver-based foundation, we are really grateful now to serve all of those families and individuals internationally through our virtual services. And I would like to take a moment to thank everybody who was able to provide a donation for the workshop this evening. Without support from our community, we wouldn't be here. So thank you so much. If you're interested in donating to EDF, I will put a link in the chat and an informational link for our website for our support services. This evening, if we have time, we might do some Q&A. The chat is kept confidential and private, so you can send any questions or comments to me, and I'll respond to you. And we'll see if we have time for our presenter for some Q&A. And now I'll pass over to Nicole. Thanks for being here.
Yeah, thanks, Sabrina. Good evening, everyone. My name is Nicole Rains. I'm the Regional Outreach Representative for Athlete Edge at EDCare, and I'm really excited to be here and be a part of this. So thank you. A little bit about Athlete Edge. It's a Denver-based program that provides intensive, compassionate eating disorder treatment from professionals who understand the world of sport and the challenges athletes face. It offers unique and sport-specific programming, which includes sport and performance psychology, strength and conditioning, sports nutrition, and sport-focused group therapy, which helps athletes get back to doing what they love. Our team strongly believes in collaborating with the athlete's family, coaches, athletic trainers, and other sports professionals to ensure that the athletes return to life in sport feeling confident, hopeful, and healthy. Tonight, I have the pleasure of introducing you to Dr. Amy Laurent, who is our attending psychiatrist for Athlete Edge. Dr. Laurent completed her undergrad degree at Loyola University in Chicago, and then she went on to complete medical school at Michigan State University College of Human Medicine and residency in psychiatry at Good Samaritan Hospital in Phoenix, Arizona. Dr. Laurent is happy to be a part of the Athlete Edge program to ensure athletes are addressing their mental health needs as much as their physical needs to achieve optimal performance in a healthy way. She is also a member of the International Society for Sports Psychiatry and working toward additional certification in sports psychiatry to better serve this population. So with that, I will pass it off to you, Dr. Laurent. Thanks for being with us.
Thank you, Nicole. And thank you, Sabrina and EDF for having us. And I'm very happy to be here and part of this series, and the series that the titles strategically spell edge. So tonight we're doing an Endgame for Recovery, Medication Management, and the Psychiatrist role. My colleagues, Dr. Riley Nichols and Linda Steinhardt, Allie Dunsing, and Brandon Kress. Hopefully you were able to see their presentations as well. I'll refer to some of the things that they talked about as reminders, and because they're important, but focus more on my role with the team. And here are their smiling faces. And also Dr. Lindsay Landgrave, who's our primary therapist for Edge, and Nicole, who you just spoke with. I also want to mention that every patient that comes in and is admitted to Edge is assigned a family therapist as well. And they are also seen daily and frequently by our medical staff for labs, weights, medical management. So shout out to them as well. This treatment team is very specialized with eating disorder experience and knowledge about sport culture and athletes. And as a psychiatrist and an advocate for mental health in general, I want to zoom out a little bit and talk about mental health as a issue in our society as a whole. One of my other interests is cultural psychiatry. And so I really enjoy understanding the culture that a person exists in and how mental illness presents itself in that culture, and how people respond to people with mental illness in different cultures, and how easy it is for them to get treatment. So we are going to look at some numbers from NAMI about mental health in our society as a whole. And you can see here that 1 in 5 adults and about 1 in 6 youth have mental health diagnoses or illnesses. And if we look at more marginalized or minority populations, the numbers are much higher, with LGBTQ being upwards of 44% with mental health struggles. So more people are suffering from mental health problems, and the pandemic definitely aggravated that condition, that chronic problem, and specifically eating disorders also with significant isolation. Detection and treatment of these issues are really a problem in our society as a whole due to continued stigma, although I think it is getting better, and limited resources. Insurance and cost of healthcare in general is also a problem. There's a significant shortage of psychiatrists and mental health providers in general, and 2/3 of primary care doctors report trouble finding mental health specialists to refer their patients to. Athletes are one group that also struggle with mental health problems, and thankfully some pretty significant athletes have come forth in the last couple of years talking about their mental health struggles, which I think has been really important for destigmatizing it in our society in general, but for them as athletes also, because their mental health is just as important as their physical health. And they're human. I think sometimes when we see athletes perform, they appear superhuman in their ability and athletic agility. And so it's important to remember they're human beings, and they have struggles, and they have different pressures. And so having a sport-informed team, I think, is really important, and really looking at their risks as far as mental health. Their entourage, as we say, an athlete's team of people, their team doc, coach, athletic trainer, all of their support people are really important in creating a healthy environment for them, and being willing to address mental health issues, and giving athletes permission to be human and to have struggles and get treatment that they need. So I also feel really grateful to EDCare for even having a program that is specific for this population, and also treating eating disorders in general. So this is just a slide that kind of shows cultural influences and barriers and difficulties from a general standpoint when treating eating disorders specifically in athletes. So just general stigma, like I talked about, for eating disorders in particular, there's a lot of self-stigma and shame and guilt around their disorders. And then for athletes, there can be stigma from coaches, teammates, and the sports culture in general. Mental wellness not being a priority in our society, and by that I mean like resources and access to care, societal emphasis on body with regards to eating disorders. And then for athletes in particular, just this idea of mental toughness, and that their physical wellness is overemphasized compared to their mental health. Lack of communication in general about mental illnesses, with eating disorders in particular, a lot of secrecy and denial about their illnesses, both the patient as well as the people in their lives. And then for athletes, just can be a lot of information about nutrition or clean eating or overtraining. A lot of athletes will say, more is better. And also just feeling a lot of fear of being pulled from their sport or not getting playing time if they speak up about their mental health issues. Next line, lack of knowledge and screening for mental health. I think most of us have probably been to our primary care doctor and been screened for anxiety, depression, suicide. So I think that is getting better as far as people being screened for those things. primary care doctors are definitely the first line of treating mental illness, because most people are more willing to go to the primary care doctor and not just go directly to a psychiatrist if they're having difficulties. So really important that people are being screened and attended to there. So I do think that that's improving. For eating disorders in particular, I hear a lot of patients say things like, well, my doctor told me my labs were normal, so everything's okay. Or when I talk to primary care doctors or team docs, they might say things like, well, I felt like there might be a problem, but I really wasn't sure what to ask. So just a lot of misunderstanding or lack of knowledge about how to address eating disorders. And then with sport, a big problem is normalizing issues in sport that actually are related to eating disorder and acting as if it's normal. So a good example of that is when an athlete has a low heart rate and they're actually, in their eating disorder, and it's dismissed as, well, you're an athlete, so that's fine. Or a young female athlete who is not having periods, and it's like, well, that's just because of your training schedule, so it's fine. When really that's their body, alerting them and everyone else that there is a problem. And then the last line, like I mentioned, lack of resources and providers for eating disorders, lack of ED-informed providers, and then lack of sport-informed providers for athletes as well. And also just a lack of easy confidential access to mental health for athletes when they have, really busy schedules and are concerned about, other people knowing about maybe their team or coach, their teammates or coach, wanting some privacy. So, a way to get around that would be to have mental health resources embedded in athletic departments or training facilities where people could get easy access, kind of like a lot of primary care doctors are doing that now, or health systems where they have mental health embedded in primary care practices, which I think is fantastic and makes it much more accessible to people in general. So as a psychiatrist, I diagnose and treat mental disorders, and we use DSM-5 as our guide. And it is a guide, and you can easily go through and just check off the symptoms and say, oh, you have this diagnosis, but it really is more encompassing than that. And we really use a biopsychosocial approach to understanding the whole person and guiding treatment. So it's really important to recognize life circumstances, relationships that a person has, medical problems that are impacting their mental health, and then strategizing on what things need to be treated, what are adaptive, what are dysfunctional. So we prescribe psychiatric medications or psychotropic medications to minimize symptoms, decrease suffering, and increase functioning. And I spend a lot of time collaborating with other providers, whether it's primary care doctors, therapists, specialists, support system, primarily to gather family history. And what's really nice, again, about Athlete Edge is that I'm able to do that all within the same workspace where we are all working as a multidisciplinary team. But we also do a good job of communicating with outpatient providers before people come into treatment, and then bridging that gap back to their outpatient providers when they leave. Yeah. And so this is just a diagram of the biopsychosocial model and kind of all of the factors that might be included in the biological, social, and psychological aspects of a person that we are always investigating and looking into to really get a good understanding. And oftentimes when we're looking at these things, we're kind of looking at them as, what things are predisposing, like maybe genetics, and what things are precipitating events, maybe a trauma early in life, and then what things are perpetuating, like maybe substance use or something that's continuing to impact mental health. So looking at all the factors and trying to decipher what's what and what needs addressing. So just a basic example of looking at something from a biopsychosocial model is like the symptom of irritability. So somebody might come in and complain of irritability, but it could be underlying depression. It could be part of a cycling mood disorder. could be a symptom of generalized anxiety disorder. They could be diabetic and their blood sugars could be all over, and that could be causing irritability. If they have an eating disorder, it could be lack of nutrition causing irritability. Insomnia, most people are irritable when they don't sleep. Substance use, if they're using or withdrawing from substances, maybe they just had a breakup with a partner. They're having pressure at work and feeling, feelings of a failure or just stress from work, and that could be creating irritability. So all of the factors that are involved and trying to suss that out and figure out how to help them, whether it's therapy, medications, change in lifestyle, whatever it might be. This approach is especially important with eating disorders because as we know, there are multiple factors that go into the development of an eating disorder, genetic being one, but also personality traits, as well as the medical repercussions and consequences of an eating disorder. So a lot of factors that go in to these disorders. And I guess the biggest thing I want to point out here is definitely the physical consequences need to be addressed from a medical standpoint, but this little cycle right here becomes a vicious cycle if the mental health problems are not also addressed. So depression, anxiety, poor coping can lead to eating disorders, and then eating disorders lead to malnutrition, which then again adds to mental health problems. And so just treating the eating disorder or just treating the medical complications isn't enough. The comorbid mental health problems also have to be addressed. And that is the name of the game with eating disorders, is comorbid mental health problems are always present. Almost always, shouldn't say always. This is just another graphic of kind of the same thing, but from a sport perspective. And so reds is relative energy deficiency of sport. And this can happen intentionally or say with an eating disorder, or it can happen unintentionally by an athlete who's just underfueling and overtraining, or one or both. But on the left-hand side here, it shows kind of all of the different systems of your body that are affected by, an imbalance in energy over time. And the thing I want to point out here is this little arrow here is the only one that's like this, but on psychological factors lead to low energy or energy deficiency. And then that energy deficiency goes back to promoting more psychological issues. So on the right-hand side here, this is just some of the performance implications of being in a red state. So athletes and eating disorders, they're a very high risk population for eating disorders, with the prevalence being up to 45% in women and 19% in men. Weight sensitive sports are on the higher ends of those percentages, with sports like gymnastics, cross country, rowing, figure skating, very susceptible to eating disorders. Oops. And just want to point out that sport culture does not cause eating disorders, just like families don't, or any one factor. It is definitely can have an influence because of its emphasis on weight and body size and shape and certain pressures that come along with being an athlete. And it can also influence if people within that culture are not screening for these things and addressing them as concerns arise. And this is just a pretty way to list all of the different factors that might be involved with culture and sport culture in particular. And so just to look at this again from a biopsychosocial model, like team environment, if there's a lot of disordered eating or eating disorders within the team, maladaptive coping going on, or if say an athlete has a conflictual relationship with their coach, that could be a stress and factor, or uniforms that people have to wear, and body image issues. Performance level, there's studies that show that the higher the athlete is performing at a higher level, the higher the risk. And this is a slide that Linda had shared as well in her talk, and I think it's a really great example of the shared characteristics of a competitive athlete and an eating disorder, and how they can be very similar, but one is adaptive and one not so much. And so some of the ones that we see really frequently: perfectionism, and emotional control, the use of the eating disorder to control emotions, excessive exercise, denial of discomfort, where a patient is just ignoring their body's cues and alert system, whether it be pain or hunger. And the difference is for an athlete where they're maybe pushing through pain for the purpose of performance, but not harming themselves, and mental toughness, or being their best, but not being perfect. And so I think in treatment with Athlete Edge, we're trying to get patients, through therapy and sometimes medications and nutritional rehab and all of the facets that we use to move from this side over into this side, and have a healthier relationship with sport. So eating disorder as coping, this is something we talk about a lot, is people managing their emotional distress through their eating disorder. And athletes are dealing with a number of different pressures that maybe other people aren't, and pressure to perform is certainly one. Stress of juggling training schedules, work schedules, school schedules if you're a collegiate athlete, relationships or having time for relationships, just the demanding schedules of training and travel if they're competing. And then transitions, we talk a lot about transitions being a vulnerable time for people as far as eating disorder development, and athletes have a lot of transitions. So transitioning to college from home, it could be just a general transition for people, but for athletes, that's not just that transition, but it's also the transition of increased training and increased training load from going from a high school athlete to a college athlete, and that can be an added stress to an already stressful situation. Sometimes we have athletes that have moved away from home even before college, to be close to a training site or a certain coach, and that can be a vulnerable time for them as well. Injury or surgery or being removed from sport for any reason could be a vulnerable time and a lot of stress for an athlete. And then retirement, whether it's planned or unplanned, can definitely be a transition time that is difficult. Like I mentioned also, like even just the transition of coming into treatment and then leaving treatment can be really stressful. And we try to really coordinate with outside providers and educate the patient on what to expect and kind of how those transitions are going to go. Eating disorder and injury. So again, athletes are very prone to injuries just because of what they do, and stress or inattention that is untreated can predispose them to injury, physical injury. And then when they are physically injured and have to be removed from sport for treatment or surgery or whatever, then that is kind of a setup for an eating disorder. A lot of athletes will say, well, I was training this much and eating this much, so I'm not training now, I don't need to eat, or I don't deserve to eat because I'm not training and I'm not with my teammates or competing like I've let down my team or my coach, whatever. And I put injury there in quotes because we tend to talk to patients, athletes, about their eating disorder as an injury also, because they can understand that concept that an injury requires rest and treatment and support, just like any other injury. It is a very difficult decision for athletes to come into treatment, and they tend to be in treatment for a long time. And so just having them view it as that kind of concept, I think, is helpful. And here at EDCare, we treat the injury while we are using therapy and groups and processing to help them increase their coping and connection and their relationship with themselves. So we use a treatment philosophy of CAMSA, which is connection, acceptance, mindfulness, sense of self, and action. And if we think about this in terms of the athlete in particular, like connection might be staying in contact with their teammates or their coach while they're in treatment because they feel isolated and separated. Acceptance is accepting their eating disorder and the need for treatment, or any other mental health problems that they're dealing with. Mindfulness and using other behavioral techniques and skills to calm their symptoms and be present in their bodies. Sense of self is in general, but also just identifying who they are outside of sport. Because some people get very focused in on their athlete identity only, and broadening that out is helpful and more adaptive. And then action, if any of you had listened to Allie and Brandon's talk, we really incorporate training when the patient is medically stable and ready for that psychologically. And that is part of action as far as returning to their life outside of treatment, with an action plan of behaving differently and participating in sport in a different and healthier way. And thank God we have therapy and family therapists and all other kinds of treatment that we have, because we aren't very great with medications for eating disorders. There are only 2 medications that are approved, FDA approved, Prozac for bulimia nervosa and Vyvanse for binge eating disorder. There are no treatments for anorexia nervosa or ARFID, although olanzapine in low doses has been shown to be helpful for both. So truly food is medicine, in that many of the medical consequences of their eating disorder are resolved just by nutritional rehabilitation while they're here in program. And also a lot of their psychological or psychiatric symptoms improve as well. Mood symptoms or anxiety improve, sleep usually improves, fatigue. So food is really our best medication. When we know that that nutritional rehab is going to help quite a bit, we tend to be patient and wait and watch and investigate, and don't just throw a bunch of meds at our patients. We kind of try to get to know them and see how they respond to the nutrition. But as it becomes clear that there are underlying issues that need treatment, then we might start incorporating medications to treat comorbid or co-occurring conditions. Because like I had said before, not treating those really sets the patient back up for relapse through that cycle of perpetuating the eating disorder and physical problems, as well as the mental health problems. One of the other great things I think as a psychiatrist I find about working here with this population is that patients don't like it if they're in treatment for a long time, but for me as a provider, I am able to really get to know patients over time. I get to see them very frequently. I get to interact with the multidisciplinary team, so I am getting a lot of information and really get a comprehensive view of the patient, and that is just kind of unheard of in healthcare, I guess is the best way to say that. So what are the comorbid conditions? These are common psychiatric conditions that we see in athletes specifically, and I highlighted eating disorders in red because it's high risk. And the ones above the red with the asterisks are typical comorbid conditions with eating disorders also. So we're going to kind of talk about some of those in particular. I guess other common comorbid conditions with eating disorders, but not necessarily with athletes, would be personality disorders and substance use, although you can see that in athletes too. So the International Olympic Committee did a consensus statement on mental health in athletes in 2019, and they looked at all the studies out there, which were not a whole bunch, but to compare prevalence rates of mental health disorders in athletes with the general population, and this is what they found. Eating disorders were definitely different and higher. Sleep problems were higher in athletes. PTSD and trauma is higher. ADHD higher in athletes. Suicide was actually lower, and I know in recent years there's been a number of reports about collegiate athletes committing suicide, and it is important that that information get out there for awareness, because any suicide is too many. But as a whole, compared to the general population, athletes have lower rates of suicide. And over on the left-hand side, depression and bipolar mood disorders seem to be about the same. Psychotic disorders, not a whole lot of information out there, but seem to be about the same as the general population. Anxiety seems to be about the same, except for OCD and except for generalized anxiety disorder when an athlete is injured. So other psychiatric considerations for athletes in particular, as far as prescribing, is that it's important to really have a understanding of medications and how they might negatively impact performance, and choose medications wisely. Obviously, we always want to choose medications wisely, but with a specific idea of kind of how this might affect performance depending on the sport. The second thing is therapeutic performance enhancing effects. And what that means is treating underlying conditions, so therapy, which will lead to improved performance for an athlete. And what I mean by that is, like, if a patient has an underlying depressive disorder and we treat their depression, then by treating that, by giving therapy, then their performance should improve because they're not struggling with that depression as much. This isn't really, a lot of patients will say that's giving me an advantage. Well, no, it's not giving you an advantage. It's really putting you on equal playing ground with your competitor who doesn't have depression. 3 is just looking at specific safety risks that might be issues with sport. And then 4 is having an understanding of the non-therapeutic performance enhancing effects of substances and knowing regulatory bodies and processes for getting approval for certain medications that might be banned. An example of that would be like stimulants are prohibited typically in NCAA, but they do have a process that you can get an exemption if you do have a diagnosis of ADHD, say. But if you don't have that diagnosis and don't have that exemption and you're using stimulants for performance, then that is not good. So when talking with athletes about medications, this is a struggle. And in general, nobody wants to take medications, I don't think, really any kind, much less psychiatric, but sometimes it's necessary. And so athletes are pretty tough on this. They don't want to take medications typically. And a lot of that goes back, I think, to mental toughness and feeling like they're weak if they have to use a medication or need a medication. Or they might say, well, I do have some symptoms, but I'm not crazy enough to need medications, or it's just situational. It's just because I'm not competing right now, or I really want to do it myself. So that's self-reliance. And a lot of times I'll have conversations with patients about, the difference between your mind and mental skills and your brain as an organ in your body. So your brain is a mass of cells in your skull, like any other organ you have. And to think that you can use mental skills or mental toughness to change your brain chemistry is just not going to happen. Just like you can't use mental toughness to, dictate how much insulin your pancreas puts out. So a lot of times I think when athletes can look at it in that way, then they'll say that they feel a little bit of a sense of relief, like they don't have to keep trying so hard to impact or change something or fix something that is not within their control to fix. Some other concerns that they usually bring up, fear of side effects, which again, anybody that's taking medication, usually is maybe not fearful, but at least wants to know about and concerned about side effects. But for athletes, especially athletes with eating disorders, they're concerned about weight gain, just like most of our patients. they get real concerned about negative impact on performance. Like if their runner is going to make me slow and it's going to take away my edge, pun intended. And family members can often influence medications, and when they have certain ideas about what medications an athlete should be taking or not taking. So a parent might say something like, you're better than that, you don't need that, you can handle this, and really influence them in the direction of no meds. Like I said before, sometimes this fear of an appearance of an advantage, or it's a crutch, or if I succeed in my sport, then it's not really me if I'm on a medication. So just educating them about the difference between performance enhancing medications and performance or therapeutic treatment. And then also, like I mentioned earlier, lack of or fear of lack of privacy, or my coach might find out, or my teammates might think differently of me, or whatever it might be. So, I think communication with an athlete support system is really important, but really only do that with their permission. And I usually, if I'm going to contact their team doc or a family member, whoever it might be, I usually ask the patient, do you want to be present for the discussion? Is there anything you don't want me to talk to them about? Really get their input on and have them feel comfortable with that communication. We also do a lot of empowering patients to communicate about their process and treatment with their family members, their athletic trainers, their coaches, roommates, whoever it might be, and have really seen some great success stories with patients feeling really empowered to speak up about what would be helpful for them when they return to sport. We're going to spend a little bit of time talking about these specific conditions that are higher prevalence with athletes, and eating disorders. So trauma is one, and trauma can occur prior to sport or during sport. Can be like a physical injury, or can be, unfortunately, we've seen some of this in the media also, like physical or psychological abuse for athletes, or bullying. Injury can be an inciting event for trauma, and if it's not detected or treated, then there can be a lot more consequences and morbidity from not treating it. Maybe an acute stress reaction will turn into full-blown PTSD. There is some research that musculoskeletal injuries in particular show a lot of hyperarousal and avoidance afterwards, and can compromise athletic rehab or performance. This might be like an athlete who is injured running hurdles and then is avoiding going back to train, and maybe avoiding certain situations or places that remind them of that trauma. It's important to note too that this trauma, like an injury for an athlete, could also be something they've witnessed of a teammate. It doesn't necessarily have to be something they've experienced directly. So the other thing that makes a diagnosis of trauma difficult in athletes is that they have been in their sport for a long time and are very skilled at compartmentalizing, like blocking out all the exterior noise so that they can just focus on their performance, and even at times disassociating, separating their emotions from their physical body to be able to perform. And when this is a skill and you have trauma, you can very quickly compartmentalize the trauma as well. And so they don't necessarily report symptoms, and maybe aren't even aware of the symptoms that they have. And that really makes diagnosing and treating difficult. Like I said, avoiding situations or places can be a clue. Athletes might present with more somatic complaints, or might overtrain to try to cope with the distress that they have from the trauma. SSRIs are typical that we use in athletes as well as anybody else with PTSD. Have to have a lot of caution with using blood pressure medications. Prazosin is really helpful for nightmares. But with eating disorders specifically, we have to be really careful with low blood pressure, even with athletes too at times. So we have caution with those medications, even though they can be useful. Beta blockers are kind of interesting in certain sports. That is a prohibited medication to be on because it treats tremors. So if you are a golfer or archery or shooting or something that needs a steady hand, then those medications cannot be used. Benzodiazepines for anxiety with athletes is tricky, and eating disorders because of people being at fall risk. But sedation also can be of concern. Benzos can lead to dependence. So if somebody has a substance use problem, that could be an issue. And also for athletes in particular, benzodiazepines are great for anxiety, but they are also muscle relaxers. So might not be the best choice for performance. So typically if we use benzos, it would be very short term. More on anxiety, generalized anxiety disorder. We see a lot with eating disorders and a lot with athletes, especially injured, and trying to, parse out the difference between the types of worry. So is it excessive worry just about eating and food and body image, or is it general worry about my family and finances and school, or is it all sport related kind of worries? In treatment, a lot of times, athletes will worry a lot about their changing body and the impact of that on sport, and when they're going to get to return to sport or training. And oftentimes are fearful that they're going to not perform as well without their eating disorder. And this kind of goes back to that table about characteristics of athletes versus eating disorder, and just their idea that the eating disorder gave them this perfectionism and self ability to like endure, and that they need that to be able to be successful as an athlete. So really just trying to educate them that that a nourished body and a fueled body is going to be their strength in returning to sport. Some other things with generalized anxiety disorder is not just the excessive worry, but the other symptoms that are included with that diagnosis are all symptoms that could be seen with an eating disorder. And so just trying to figure out which is which, and that might be a case where maybe we don't make the diagnosis until a little bit later after they've had some nutritional rehab. Obsessive compulsive disorder is also one we see a lot with eating disorders and with athletes. And looking at the obsessive thoughts and rituals, whether it's just food, body image versus compulsive exercise, or is it other rituals that are related to sport? So a lot of athletes have rituals that help them focus before performance, and those are helpful, and those are adaptive, not like compulsive rituals that take a significant amount of time and take away your focus because you're so caught up in your compulsions. Another thing to kind of look at is obsessive compulsive personality disorder, the rigidity of that compared to, say, the cognitive rigidity within an eating disorder. So really trying to get a handle on the anxiety and where it's coming from and how best to treat it. Depression is equal, as I showed you on that list, in athletes with the general population, but just like the general population, female athletes are higher risk than males, just like females are higher in the general population. Important things with this, the symptoms are listed here on the left as far as diagnosis of depression, and it's important to distinguish that again from the eating disorder. A lot of those symptoms overlap. Grief, when an athlete is pulled from sport or in treatment, they're grieving that loss, grieving their teammates, coach, their life, and so that can be an appropriate reaction and not necessarily a depressive episode. Overtraining, people that overtrain can exhibit very similar symptoms of like low energy, poor concentration, fatigue, sleep problems. And so what's interesting about that is that if they're overtraining and have those symptoms, if they stop training and take a break, then their mood improves. But if they have an underlying depression and they're overtraining, and that's modulating their mood, then when they stop exercising, they're actually going to feel more depressed. So it's one way to distinguish those things. Like I said, halting exercise when people come into treatment is really a difficult time for them, and just creates a lot of anxiety, fear about ever returning to sport or ever being successful again, and really work with them on managing those symptoms and understanding the importance of why we do that. This I just thought was interesting to add. It's a screening tool for depression for athletes, and kind of takes those symptoms and puts them into questions related to sport. So I get little or no pleasure from my athletic successes. I have trouble maintaining focus during competitions or training. Like I said, female athletes higher than male athletes, but overall the same in the general population. Interestingly, individual sports participants seem to be at higher risk of depression than team sports, and there's a lot of thoughts as to why that might be. And track and field specifically is highest. So females track and field would be the highest. As far as medications with depression, Wellbutrin for a lot of sports psychiatrists is their #1 choice for depression in athletes, because it is not going to impair or impede performance at all. But unfortunately, Wellbutrin is black box warning medication for eating disorders. So usually SSRIs are a better choice when the conditions are there's comorbid eating disorder. Just a word on lithium. Lithium is a great medication as an adjunct for depression, or also for bipolar disorder, but for eating disorders and athletes, just not a great choice because of potential dehydration, decrease in renal functioning, and becoming toxic easily. Athletes, the dehydration with training, but eating disorders and malnutrition is the risk. Attention deficit disorder, untreated. A lot of people might go into sports or participate in sports as a way to manage their lack of focus and hyperactivity. People might overtrain if they are hyperactive and just require excessive movement. So trying to figure out a diagnosis of ADHD versus excessive movement with an eating disorder. When ADHD is untreated, people are at risk of injury due to inattention. And then, like I said before, injury can be a setup for eating disorder. It can be a setup for trauma, PTSD. People with ADHD also are prone to depression and substance use, in part because they get frustrated that they can't manage their lives. They have difficulty connecting socially because they interrupt or they don't pick up on social cues or those kinds of things. And so can lead to social isolation, which potentially could lead to eating disorders. So there can be overlap with these conditions. Stimulants are often a #1 choice for ADHD, but it can aggravate an eating disorder with decreasing appetite. Can be problematic for sleep and anxiety, and are also, like I mentioned earlier, have to have approval for to be used in athletics. The other part of that is, even if a stimulant is appropriate and an exemption is given for an athlete, they might be more vulnerable to heat illness with it. Sleep and safety, just a couple of things here I've mentioned a couple times, is the busy schedules of athletes, and sleep can be the fallout from that. Malnutrition, anxiety, depression can cause sleep problems as well. And then other factors like the environment they're in, roommates that maybe aren't athletes and are on a totally different schedule, pets or other things that might disrupt sleep. Sleep hygiene or CBT for insomnia are the best choices. Medications, just want to be careful of daytime sedation, incoordination, melatonin might be a good choice, but it is not FDA regulated, and there could be contaminants in it, and an athlete potentially could test positive for a banned substance if it was one of the contaminants in there. So just getting a single ingredient melatonin is important. And then, like I said, taking away training and being away from sport and treatment can create depression and anxiety and fear, and sometimes suicidal thoughts or self-harm urges come up in treatment. So we're always assessing that. And naltrexone is a medication that can be helpful for non-suicidal self-injury. So in conclusions, this is complicated. A lot of factors to weigh in with athletes with eating disorders, and food is the best medicine, and a biopsychosocial approach is really important to investigate all factors and treat underlying issues. And a very thoughtful, low, slow use of medications is also recommended. Mental wellness is just as important as physical wellness or physical excellence when it comes to athletes. This treatment's necessary. Eating disorders are life-threatening conditions, causing a lot of disability and suffering, and for athletes can really can impact performance. And so treating those comorbid conditions really adds to well-being, but also solidifies recovery. And then just some of the other considerations I said, as far as athletes, they're humans. They have high stress and demands on their lives, and they're at high risk of comorbid disorders. And so they really benefit from education and permission to seek help and access to care, and care that isn't, what do I want to say? Enabling any kind of entitlement, but is considerate of their demanding schedules and their privacy. And this is just a good visual, I think, of all the players that are involved with treating athletes, kind of the ones in the middle and up above, kind of all the people that we have at Edge that are involved in an athlete's care. And then the ones on the bottom are really not really the administration, but the coach, trainer, physical therapist, or team doc are people that we're communicating with throughout treatment. And then these are just some slides of Edge. Some of the groups that we offer, communication that we try to incorporate, and then incorporating training. This is our gym. Yeah, and I think that's it.
Thank you so much, Dr. Laurent. I've had the pleasure to visit that gym in space, so that's really exciting. That's really cool. Yes, so if anybody has any questions, now's a good time to put them in the chat. I do have a couple already, so I'll go ahead and just get started with those. It seems like this question might be from a professional. So the question is stating, I'm working with somebody, an athlete, who they think would benefit from medication for depression and anxiety in their recovery. It is because the client knows that certain medications might fluctuate weight and increase weight gain. How do you navigate this concern and general closed-mindedness about medications?
Yeah, it's a tricky question. Or it's a tricky situation, I guess. I think what I normally try to do with patients is really give a full, risks, benefits, pros, cons kind of approach. And, depending on how much the depression is really interfering and becoming an obstacle in their life in general, or as an athlete, weighing the benefits of taking the risk. I mean, just because a medication has a side effect of weight gain doesn't mean they're going to have weight gain. So taking the risk to try the medication and say, hey, as the provider, let's really monitor closely. And, you're not married to this medication. If it turns out that you're having a side effect that you don't like, whether it's weight or anything else, that you're not comfortable with, then let's just keep that communication open and we can look at some other options. So I think it's trying to just get them to trust the process and trust giving it a chance, and knowing that once you're on a medication, it's not like you have to stay on it forever. And in trying to highlight what the benefits of being on that medication might be. I think if those benefits outweigh the side effects, or even we're actually talking like potential for side effect. And then I think you can pick medications that tend to have less side effects. So of the SSRIs, for example, that treat both anxiety and depression, gravitating more toward, say, Prozac as opposed to Paxil. Some tend to have weight gain as a higher risk.
The next you kind of mentioned a little bit. The next question is, in the clients that you've worked with this intersection of athlete and eating disorder, do you have an idea or a rough kind of estimate with the clients you've seen on average, or is there an average that you could say, like, do people stay on during their sport or during their active recovery while they're actively in sport? I mean, is there any kind of measurement or average that you notice to people staying on or then getting off their meds?
Staying on beyond treatment, I guess I'm staying on medications beyond treatment or during treatment.
That's correct. Like, do they stay on beyond treatment?
Yeah, I don't know the answers to that. I mean, we do have sometimes patients or athletes that leave treatment will sometimes reach out and give us an update and just give us a general idea of how they're doing. But those are never really involved question or exchanges where I might know what they're taking as far as medications or anything. So I don't really know that, but it'd be a curious thing to look into.
Yeah,
I do. I mean, I will say that I really make an effort to contact their team doc or primary care physician or whoever is going to take over that prescription when they leave, and really talk to them in detail about, maybe some of the concerns the athlete had, and kind of like pass the baton, so to speak, to their outside provider so that they can continue kind of the process and the communication with the athlete about the medication, and hopefully they can be successful in that and continuing that if it's been helpful. Yeah.
Well, I like what you said about even introducing the idea of, in recovery, we do have to take risks, and it can, the only way we can see if that will actually help or benefit in the future is if that risk is taken. And so you said we don't have to be married to a decision, but to try something out that could have a benefit, it is worth it.
Yeah.
So the next, maybe we have time for one more.
I think it's important to tell them, communicate to your provider. If you're not happy, tell them, like, speak up, use your voice, which is something we really work on here in treatment, is speaking up and speaking to your needs.
Yes. Yeah. Earlier you said having access and permission to ask for help. And I think that is key.
Yeah.
We do have a couple more questions if you have time for just one.
Sure.
Okay. Do you find athletic coaches to be supportive of their team members using psychotropic meds?
I mean, I'm just thinking of different people. I would say in general, yes. I have seen coaches be supportive of treatment in general, and that would include medications. A lot of my discussions are more directly with the team doc, who almost always is supportive of that, and not always directly with coaches. A lot of times we really just empower. I mean, unless coaches really want to have a conversation with us, or the athlete really wants us to speak directly with the coach, we really empower them to talk directly with their coach, and spend more time communicating with the team doc or a team psychologist, sports psychologist that the athlete's working with outside. So.
Yes. Well, we have reached our hour, and I just want to thank you, Nicole, and Dr. Laurent, for teaming with EDF to provide this incredible information. I've learned a lot this evening, and I'm just grateful for all the work that you do. Thank you.
Thank you.
Thank you.
So we will send the recording out probably tomorrow, and I hope that everybody has a wonderful evening. Take care of yourself, and we'll see you next time.